All right, so there may be times during the talk where I ask for participation, either live or through the chat. Like I just want to encourage you to please join and invite you to venture guesses because there's no there's no right answer to any of this, as anyone who works in behavior management from a non-pharm or even from a pharmacological lens knows. There's a lot of trial and error, and so I just want to assure everyone that this is a safe space to do some of that today. So first we'll go through some of the disclosure slides, and I do not have any relationships with financial interests. As Dr. Khan mentioned, I was part of the um, panel that developed the guidelines. I did receive an honorarium, but that is not an existing relationship, so I didn't put that in. Yeah, I don't have anything to disclose. I'm not sure if I'm supposed to read these out loud or David, what is usually done? It's been a while.
You can just briefly mention that we have funding from the Public Health Agency of Canada to
Okay.
CCSNH. That's fine. I think the rest of it you can skip over fairly quickly.
Okay. Thank you. So yeah, evidence-based information is going to be provided today. And there's going to be a survey, I guess, at the end. All right, so what we're going to be doing today is learning a couple of things. First, we're going to review the elements of a functional behavioral assessment. We're going to talk about behavioral functions and what they are, and then I'm going to share some strategies for each one of the different behavioral functions. And if you have any questions, please feel free to stop me at any time. So first, we'll talk about the assessment. So when a patient is having any sort of responsive behavior, before we can treat them, we really need to know more information about the behavior, right? We want to know what's going on. So take a minute and just imagine if you were going to design some intervention strategies. Let's say someone asked you to consult on this case and they said, so and so is wandering, like the case we have today, right? What would you want to know about the behavior first? And please unmute yourself or feel free to write in the chat. What would you like to know as you're formulating this behavior? And David, can I ask you to monitor the chat, please? Because I can't seem to do that. Oh, I figured it out. Okay, so we want to know, when does it happen, right? Is the onset insidious or sudden? What the environment is like? How often is it happening? Is there an unmet need that the person is trying to fill? And what is that need? I want to know more details about the behavior. What triggered it? Excellent. Good. Thank you for your participation. What the social environment is, what the antecedents are to the behavior, right? So what happened just before the behavior occurred? Is the person oriented? Meaning, what is their cognitive capacity like? What other symptoms, what does their physical health look like? How how is it, if at all, impacting other people around them? These are all wonderful questions that we would like to know. We want to define the behavior exactly. We don't want it to be just this vague, like I get a lot of, please see this person for agitation. Okay, well, what does that look like? What does that mean? Wonderful. So let me get back to this. Yeah, so we want to know what exactly is happening. These are all things I think you guys covered almost everything here. So what exactly is happening when, right? Is there a specific time of day or a specific activity that it's tied to? How often? What's the frequency? How long does it last? The duration? Who does it affect? How difficult is it to manage, right? Do we need 7 steps to help give this person a shower? How disruptive is it? So is it only something that affects that person, or is it affecting others, and how badly? Does it pose any risks to safety? So this one wasn't mentioned, but it is an important one, because if there's something that is unsafe, then we would need to take action faster than if safety wasn't at risk. And then we get into the why questions, right? Why is the behavior happening? Like someone said, what might be triggering it? Is there an unmet need? What's the meaning behind the behavior? What might be not only triggering it, but what might be reinforcing the behavior? So these are all the things that I would want to know before I'm going to design any sort of intervention. And there are a lot of tools available to find all those things out that we just listed. You might be familiar with some of them, like the NPI, the DOS, the CMAI. But in my work in the virtual behavioral medicine program, I typically rely on structured interview that uses elements of several tools. So like ABC charting and pieces. And I conduct what's called a functional behavioral assessment. And so here are the components. So here are the things that I typically ask when I'm gathering my information because my service is very short term. So I'm in, I'm out. Um, so the first question is, what are the behaviors, right? What are the behaviors of concern? And I'm asking people to be very descriptive and very specific, and I need examples. So even if they tell me they're physically aggressive or they're physically expressive, okay, I want examples. Are they spitting? Are they kicking? Is it aggression or expression towards the environment, towards people, towards themselves? I want more detail. And then when, right? When do you notice the behaviors happening? What are the triggers? What's the context? What's the time of day? What are the antecedents? What happens just before the behavior happened? Or another way of asking it is, when are the behaviors most likely to occur? And then the last thing I want to know is, what are the consequences of the behavior, right? So how does the staff or the family respond to the behavior? And is it effective at reducing the behavior or not? And excuse my typo here, but what is the outcome of the behavior for the patient, right? So what did the patient get out of it? And here's an example of how I collect my data, and like I put it into a chart form that goes into my report. So in this column on the left, we have the name of the behavior, if you will. Then we have examples and triggers, right? So a lot of times I get, oh, when we attempt to provide care or when, the patient feels that they're not getting their way or their needs aren't being met, when she wants something done on her timeline, um, when there's approach by unfamiliar staff, or it's most common on evenings of sundowning. I hear a lot of these are things I hear a lot. And then the outcome column, right? So what was the response of staff? What is the consequence? So what are staff doing or family members doing when the behavior occurs? And really, what I'm looking for here are patterns. I'm looking to see if there's repetition. I'm looking to see if the behaviors are being reinforced based on what staff do. And really, I'm just getting a better understanding of what's going on so that I can start to figure out what are some strategies that I can recommend to reduce behaviors. So I want to talk now about functions of behavior. Um, so we're kind of turning away from what is the behavior, and now we're going to turn to why. Why is the behavior happening? And we're gonna do that by focusing a little bit on principles of applied behavior analysis, or ABA for short. And through this lens, we focus on events that happen immediately before and immediately after the behavior to explain what the function is. So first, let's review the traditional literature. So I think a lot of you mentioned this already in the chat, or um, some of these in the chat, but feel free to unmute or go back to the chat and tell us, to your knowledge, why behaviors are happening. I'm gonna open it up here. Okay, so unmet needs, absolutely. Any other ones? There's pain, illness, right? So something physical, disorientation, that's intellectual, communication. Yep, unmet needs, confusion, fear. Okay, someone knows the seat. Joanna knows it. Um, right, the clothes could be ill-fitting. Right, there could be so many reasons. They could be anxious, they could be bored, They could be provoked by others. They could be feeling threatened. There could be medical, right? So that's their physical health. It could be a memory that evokes it, lighting or sound in the home, that's environmental. Absolutely. They could be lonely, that's their emotional. Wonderful. Thank you so much for all of these. So I'm closing the chat. And these are the three most common that you will find if you look in the literature outside of applied behavior analysis, which we'll get to in a minute. So the first one is the unmet needs model, which many of you have said. The behavior is a means of communicating something that the person needs, whether it's, they're in pain and they need pain reduction. They are lonely and they want someone to come sit with them. They're hungry and they don't know how to tell you. And so there's something that they need that they may or may not even be aware of themselves, and they're trying to communicate that to someone outside of themselves. Another common idea put forward is that behavior is learned through reinforcement. So essentially, imagine a situation where someone is exercising their vocal cords and there's some vocalizing, and people will come to check what's going on to see if there's a problem. So, you may get a nurse and a PSW or a handful of people coming to see if everything's okay. And the individual learns, oh, if I'm lonely and want people to come see if I'm all right, if I want some attention, a good way to get it is to scream or to swear or to, cause a fuss so that people will come. And so the next time they're lonely, they will do the same thing again. So it's reinforced through the environment. And then thirdly, we have the idea that people with dementia are more vulnerable to stress, and they are not able to handle their stress as well. So we all have stress in our day-to-day life, right? Like coming to work today, we were in traffic, it was stressful. We figured out how to handle it. But in people with dementia, they're unable to as well handle that. And they also perceive things as more stressful than we might. For example, a shift change could be perceived as stressful, or like some of the environmental factors that people were writing in the chat about lighting and noise and um, temperature. Those are all things that might be happening around them that they perceive as they just don't know how to manage. And so the behavior is their attempt at managing that stress. But also, what can be overlooked is internal stress. So imagine someone sitting at a concert and the music is really upbeat and lively, and everyone's clapping along. And then the next song comes on, and it's more of a waltz or a slow ballad, and the mood changes, right? So there's that internal shift of mood, and that could be perceived as stressful as well. Um, and again, this is the behavior is the attempt to manage that stress or react to that stress. Um, Now, every behavior is completely dependent on the interaction between the individual person and the environment around them. And the environment. It could be the external one or the internal one, as we talked about. And as clinicians, what we want to do is target this space right here, which is where they intersect, right? Where that interaction occurs. And these ideas are very consistent with principles of applied behavior analysis, which focuses on what happened just before, what happened just after, so that the environment plays a huge role. Um, According to Bergio and Bergio, behavioral gerontology is the study of how antecedent and consequent environmental events interact with the aging organism to produce behavior. So this is not a new concept, but it's just emerging more and more now to use principles of applied behavior analysis with an elderly population. Until this time, applied behavior analysis has mostly been used with children that have autism, but there's a real role for them in a geriatric population as well. And so I'm going to turn to why behaviors might be happening using that ABA lens, focusing on the events that happened immediately before and immediately after the behavior to explain their function, right? So what the person is getting out of it. And there are four most common reasons why someone will engage in a behavior, why any one of us will engage in behavior, not just a person with dementia. Um, we can use the acronym SEAT to help us remember what these four common functions are. So the S stands for sensory stimulation. So the function of the behavior is because they're seeking an enjoyable or comforting sensation, or they're seeking intellectual stimulation. So an example of this from our own lives would be if our arm is itchy and we scratch it, if we scratch it because it's itchy and it feels better now that I've scratched it, right? So that's something sensory. Um, E stands for escape or avoidance. And this is trying to avoid a situation, a task, anything that is perceived as displeasing, distressing, uncomfortable, anything that the person does not want to do. And that could be caused by a number of things like pain, anxiety, illness, which you all wrote in the chat. Um, so I'll give a couple of examples here. So escape or avoidance in a young child, we might imagine, and some of you have heard me give this example before, but we can imagine a young boy in school who does not believe that his math skills are very good. And one day the teacher announces that there's going to be a pop quiz in math, and everyone should put away their stuff and get ready. And this young child is feeling very distressed at the idea of having to write this quiz. And what does he do? He starts to throw spitballs at the people in front of him. He starts to make loud noise and rude jokes and just, trying to get everyone around him laughing. And the teacher, rightly so, says, "Get out of my classroom." And, he may be upset that he's going to have to go to the principal's office, but there's a tremendous sense of relief because he's escaped or avoided having to take this math quiz, right? In the case of an older adult who has dementia, if imagine the scenario where the PSW comes into the room to give the person a shower and they don't want to have a shower. And it could be for any reason that they don't want a shower. It could be because they don't want to get undressed right then, or they're scared that someone will steal their clothes, or they're worried that, you know, uh, a trauma that they had in the past is going to be relived, especially in cases where there was sexual abuse. It could be that they don't understand the intentions of the person because there's a miscommunication and they don't speak the same language, or the person is disoriented and they don't know what's happening around them. Um, it could be that they don't want to be cold right now. It it could be that they don't want to or they're uncomfortable doing being dependent on someone else for something that they used to do independently. So whatever the reason is, they don't want to take the shower. And so what do? They are physical. They might spit on the PSW. They might be verbal. They might say, "You're hurting me, get out of here." They might swear at them. And typically, the PSW will do what they are trained to do. And I'm not picking on PSWs. It could be a nurse, it could be anyone, but typically the training is walk away and reapproach or stop and go approach. And so what happens is that the individual learns. So remember, we talked about reinforcement through the environment. The individual learns that in order to escape having to take that shower, what they need to do is be physical and verbal, and then the person's going to leave. Yes, the person might come back, but they just gained 10 minutes. They just gained 10 minutes of freedom. And so that was a success. And so there's this relationship or contingency, if you will, between the behavior and the outcome. Excuse me 1 minute. Let me just grab a drink. Okay. Um, Moving along, the A stands for attention. So behavior is engaged in because they're seeking a reaction, even positive or negative attention. They want you to engage with them in some way. And finally, T stands for tangible. They want access to something specific, a food, an item, a toy, an activity, a person, a chair, their specific spot in the dining room, whatever it is. And so they want access to that. And so they may have behavior, right? It could be verbal, it could be physical, it could be anything. Sometimes people can mistake it for, oh, they just want attention, but actually they want a specific item. So I'm going to pause right there just for a sec to see if there are any questions about the behavioral functions. Okay, I don't see any. I will continue. All right, so moving on. So let's go back to our case example and we're going to look at this data. And I just wanted to know if anyone saw or can see any patterns in terms of the antecedents of things that were happening just before the behavior. Please feel free to unmute or write in the chat. What about consequences? Does anyone see any patterns in the consequences or the outcome of how staff are responding? Okay, then let's jump to the, the last question. Can anyone take a guess as to what the function of the behavior is here? Based on how staff are responding, based on the triggers, what do you think this individual gets out of the behavior? Why are they doing it? Okay, so we've got some escape and avoidance. Yeah. Uh, Control, right? So sometimes people could be avoiding the loss of control, right? The distress that they feel from the loss of control that comes with having to go on someone else's timeline or be dependent on others. Another one is wants interaction with others to engage, exactly. So there's that attention piece. So it's one can never know for sure. You don't know what's going on in another person's mind, and that's why we say potential function because we don't know 100%. Right. So someone else wrote in the chat, each consequence includes attention from staff. Exactly. And so that would be the main or the primary function that we could deduce here, which they give her attention and therefore it reinforces the behaviors. And potentially the escape could be a secondary one. But like I said earlier, there's no way to ever know 100% with certainty. We just have to go with our best guess based on the data. So I'm going to close up the chat. Based on the data we collect. And that's why it's so important to ask the right questions. And especially in a role like mine, where I don't have the luxury of being there on site and I have like pretty much 1 hour to get all the information that I need. So it's important to ask the right questions, and it's also important to listen to what people are telling you. And so once you have the information, based on this, what I just showed you, and I also include, I go through all the pieces. I also do a chart review prior to the appointment. I'm able to identify the potential function of the behavior and then develop interventions. And the whole goal of the interventions is to alter the environment so that the behaviors of concern are less likely to occur. And I'm just going to share a couple of these with you now. I think I already went over this, the idea of the set of rules, right? So there's this relationship between behavior and consequence. And so what we want to do is try to give the person what they seek. If they're seeking escape, we want to give escape without them having to engage in the behavior to get it. Or if it's attention, just giving them, like some of you have probably heard of a pro-attention plan. You want to give them what they seek without them engaging in behavior to get it. That's basically what this slide says. Sorry, I see I'm short on time, so I'm just like breezing through now. Okay, so here are some
You
interventions.
don't have to rush, yeah. It's okay. Take your time. We have lots of
Oh,
time.
okay, thank you. Sorry, I'm just like, oh my God, 20 minutes is like over now.
No, no.
Okay, thank you. Um, so depending on what we go with as the potential function of the behavior, we can tailor our interventions towards each one. So let's say we identify that sensory stimulation is the function of this behavior. And you might find that with people who are engaging in sexually inappropriate behaviors, right? You might do your assessment, your analysis, and find that they're seeking sensory stimulation. Or you might do your analysis and find that it's actually socially mediated or motivated, that it's attention that they're after. And they know that if they say help, help, someone's going to run to them at a certain rate. And if they, undress themselves in a common area and start masturbating in a common area, then people are going to run a lot faster, right? So that might be attention. So you have to sort of tease apart what the function is. Just because on the surface the behavior might look like one thing, it could be something else. Anyway, so once we've identified, here are some that we could do for sensory stimulation, addressing any medical concerns, enriching the environment with the right amount of stimulation, right? So it could be that the person doesn't have enough of the stimulation that they're seeking, in which case would want to up that through different activities, through a different appropriate situations, like for the sexual disinhibition case, allowing them some time privately with sexual materials so that they can get that stimulation that they're seeking. Or including sensory activities as part of their daily routine, depending on what sense that they're trying to stimulate. These are just examples. Um, if we identify that the function is escape or avoidance, so what we want to do is try to give them back a sense of control, like someone very rightly mentioned, that they're trying to escape from that feeling of distress of that comes along with the loss of control, the loss of independence. So we want to allow choices, um, between care tasks, between clothes they're going to wear. It's basically giving them back that sense of control in any way that we possibly can throughout their day. So, hi, Mrs. Smith, do you want to wear this shirt or this one? Right? So it's always closed-ended. Do you want chicken or fish for lunch? So giving them opportunities, or it could even be like, do you want to have your shower now or in 10 minutes? Giving them opportunities to autonomy and mastery over something is under-resourced. But the idea here is to give the person the escape they're seeking without them having to engage in the behavior to get the escape. So let's say, for personal care, we would say, okay, we're going to do care for 30 seconds, followed by verbal praise. Wow, you did so well. And a tangible reward. Here's a sticker and a break. 90-second break. So the break is longer than the care was. And then continue, go back to it until the care episode is complete. And there's a huge layout of time initially. I'm aware of that. And I know when I ask teams to do this, that they are taking a huge leap of faith, just trying it. But over time, what happens is there's a trust that builds, and the patient learns that they can get the escape without having to engage in behavior to get it. And then you can increase the intervals. So instead of 30 seconds of care with a 90-second break, you can work your way all the way up to 5 minutes of care with a 1 minute break or no break at all. Behavioral momentum, I will explain on the next slide. If we identify attention, right? So pro attention plan, I know a lot of you are familiar with it, but basically it's giving them attention on a fixed schedule. So it's like attention for free, for not having done anything. Another one would be setting an egg timer to indicate when staff will return. Like this is for someone who has repeated requests for help or for items or for attention. Say, when this rings, I'll be back. Um, High quality verbal praise, right? Being very specific with the behaviors, very enthusiastic, giving them the attention in appropriate ways so that they don't have to seek it in inappropriate ways. And finally, tangible. So using a schedule that they can see to indicate when that item will be available, allowing them access to that item on a fixed time schedule, providing enough opportunities for them to have access to that item. Obviously, it would have to be something safe, right? If they want a pair of scissors, then that's not something that we're going to be encouraging. Okay. So those are function specific, and then here's a couple of just key strategies that I use in my practice. So the first one is build behavior momentum. So it's really hard to say no to something if you've been saying yes all along. And so the momentum for saying yes, we want to carry into the activity that the person doesn't really like. So let's say you know that they liked or they agree to simple things like give me a high five, or let's see a smile, or put on these cozy socks, or help me make this bed. And then you slip in as number four or number five the request that they typically say no to, right? Like, let's go get your teeth brushed so we can get you to breakfast. So they're saying yes, 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 yes. And we put that one that they don't like as number four. As opposed to if you start off with, come, let's brush your teeth, it's much easier for them to say no outright. You want to build momentum for agreeing with you. The next one is shaping the behavior. So just gradually teaching the behavior through reinforcing successive approximations until the target behavior is achieved. So for example, if the target behavior is you want them to take their medicine, so um, gradual. So first is be in the same room as the pills without having this any behaviors. And again, with reinforcing through verbal praise and tangible rewards. And then it's holding the pill bottle in your hand for a certain amount of time. And then it's having the actual pill in your hand for a certain amount of time. And then it's putting it in your mouth and swallowing. So just slow and steady till you get till they are able to do the target behavior that you want. And then the first then approach, right? So it's, excuse me, first we're going to do this unpleasant thing, and then we're going to do the thing that you really enjoy. So first we're going to have this shower, and then I have this nice cup of coffee and apple strudel waiting for you, right? So the first then. All right. So then we have to ask ourselves, how do you know which strategy to choose for any given person? And that's always tough. And as it says here, one size does not fit all, right? It depends on so many factors, and we need to look at our data and the information we collected from our pieces, which I did not review today, but I think most of you are familiar with it. Um, and we just have to try, right? So as I mentioned earlier, every behavior is dependent on the interaction between the person and their environment, and that's individual, right? And so we just have to try and see what may or may not work. And something that works for one person won't work for another. But more than that, something that works for one person on one day may not work for that person in a few weeks' time as the disease progresses. And I always say try something at least 3 times before you can determine whether or not it's effective. Because you never know. Like if you just try it once, it could be the person had a bad sleep the night before, either the staff or the patient, or any factor could. We need 3 data points to say, yeah, we gave it our best shot and it was not a good fit, or yeah, we tried it and it actually worked 3 times, so it works. Okay, and then I wanted to share. This is one of the things that I think the most uptake of all the strategies that I recommend for my patients. Teams really seem to like this one. So most teams have some form of a tip sheet, but this is the one that I like to use. And it's very simple, straightforward. Basically, every area of activity, every like activity of daily living, plus this one section down here, which is about me. And so I recommend that in compliance with, privacy laws at your setting, putting this together with the strategies and printing and laminating it and putting it somewhere in the patient's room, so that anyone who works with a patient can see it and know exactly what is going to work. This section here is my favorite, the about me, because that gives a staff member a way to build some rapport, especially if they're not the regular staff, like if they're a float staff, or they're temporary, even for people who are working with individuals living at home. Agencies don't send the same people in every day. And so these can give you things to build conversation around, but also things to look out for. Like, for example, here, I have a short attention span for activities. Make sure I don't get overwhelmed or overstimulated by engaging in an activity for too long, or I have chronic back pain. You'll notice that I'm in pain by my facial expression, right? So just it's tips. And then just in summary, these are the stages of conducting the assessment and developing the plan. So the first step is defining the problem, right? What is the behavior of concern? Step 2, what's the function? Step 3, let's develop that behavior intervention Those are the strategies. And then step 4 is monitoring. Did the intervention and support work? Why or why not? And if it doesn't work, we go back and say, okay, did we analyze the problem sufficiently or effectively? Maybe we got the wrong function. Let's try again. Maybe there's data we overlooked. Maybe it's a different function, and go through the steps all over. I'm sorry I've taken up more time than I should. Um, I'm open for questions, and if anyone wants to reach me outside of here, this is how you can do that.
It's
Thanks very
great.
much.
Thanks, Yael. Appreciate that talk, and you've given a very, very nice overview of this particular model of applied behavioral analysis and how it can work. So let's open it up for questions. Happy for you to put a question in the chat or to put your hand up, which hopefully I would see. Question from Chantal. Is there a link to the document that has the about me and suggested interventions? She loves the format. So the question is whether there's an online version of that or
No, there
that's
isn't.
your own, yeah.
Yeah,
Uh,
that was developed by myself and one of my students, and I'm happy to share it. If you want to reach out, I can send you a copy. No problem.
Thank you. And maybe if you could put in your email in the chat,
Sure. Yeah, that's a great
in
idea.
case
Thanks.
someone missed it. Yeah.
Yeah.
And Una has her hand up. Thanks, Una. Go for it.
Hi, yeah. I'm a family physician in Victoria. Um, we don't have behavioral supports necessarily, like it seems like there are in Ontario. And what I'm struggling with is those folks who are awaiting, whose whose responsive behaviors and reactive behaviors are such that it's a strain on their caregiver,
Mm.
who are awaiting long-term care or assisted living. And I'm
Yeah.
thinking of a gentleman who every day, as the day gets on, gets more and more irritable with his family, doesn't want to do things, is really resistant to personal care, resistant to anything, and everyone's burning out. And yet he won't accept anyone in, and
Yeah.
how to support that family.
Yeah, I thank you for bringing that forward. I don't know about the supports that are available in BC, but perhaps others on this call might. Um, but I see room for intervention on several levels. The family needing supports for caregiver burnout, and potentially that could be achieved through social work, through the Alzheimer's Society. I think every province has a chapter that provides resources and support for
Yeah, the wife
families.
is connected with a talking circle through Alzheimer's Society. That's
Great.
great. Um, they're both getting their own mental health support. I think the thing is that he won't accept respite. He won't accept anyone in.
Mm.
It's all on them.
Right. And so I think there comes a point at which capacity has to be evaluated.
Mhm.
And, there comes a time where it's actually no longer going to be his choice.
Yeah.
And that might be, I can't speak specifically to the case. I don't know all the details, but I think that's something that needs to be considered, double checking if there's a power of attorney in place,
Yeah.
and invoking it. Because if it's got to be the environment has to be safe for everybody, not just the
Right.
identified person with dementia. And it, yeah, help
Yeah.
is needed, right? And so
Yes.
people reach a point where they are not able to make decisions in their own best interests. And I think,
Exactly. Okay.
like,
Thank
again,
you.
I can't. Yeah, it sounds like it's that point has been reached.
Yeah.
Thank you. And thanks for the resources that several people have put into the chat. Appreciate that. Um, thank you. Okay. Any more questions for Yael? I guess I've got one. That is, when it comes to non-farm recommendations, the guidelines have a list of various things. They range from music therapy to aromatherapy to massage therapy to exercise to robotic animals and things like that, and they're all, and there's evidence, some evidence for all of those. That's how they got into the guidelines. Evidence-based is the way to get into the guideline. Could you just mention how one might consider supplementing a behavioral analytic approach with some of these other potential interventions? How do you see it? Because it can be so difficult for the clinician or the team that's looking at these guidelines. There's so many possibilities outside of pharmacological interventions, a whole array of other options.
Yeah.
How do you decide which ones to try out?
You know what? I'm really glad you asked. So I used to work on the behavioral neurology unit here at Baycrest, which
Right.
is 4 West, 20-bed inpatient unit. And at that time, I had not yet had ABA training. So I was relying heavily on the types of resources that you just mentioned in terms
Mm,
of the evidence-based, the massage and the aromatherapy and the, simulated presence and all these
yeah.
kinds of things. And I found that I just my my practice sort of hit a wall. Like
Mm,
it only took me so far, and I felt like there's got to be something else out there.
mhm,
And that's when I ended up going back to school and getting the training that I needed. Um, and I find that they actually work really, really well together because once we can identify what the function is, we can use any of those evidence-based strategies to help provide that function, right? So if we think about some of the ones you mentioned, right? Like the aromatherapy, that could be for the stimulation piece, right? Um, to provide a calming environment versus not massage, music, again, stimulation. A lot of them have to do with stimulation because I think
mhm, yeah.
that's what the studies have been focused on. But I think you're pointing at something that's really, really important, which is there's a paucity of literature. So we can't say that a lot of these things are evidence-based for a geriatric population, not because they don't work, not because we don't have evidence that they work, but we have not been able, or people have not yet, to this point, conducted the research to be able to say, yeah, this is an evidence-based
Mhm.
approach, or there's evidence for it. Um, there's like N of one or N of two, like, case studies that are out there, but we need more. We need to be publishing more.
Okay. Thank you. Okay, I think we should move on. We're actually going to have a quick poll before we go to the case. So one of